Hello everyone, let's learn about myocardial infarction today. What is myocardial infarction? Myocardial infarction is in fact a combination of ischemia, myocardial ischemia plus acute myocardial injury, okay? Acute myocardial injury. So, what is ischemia? Ischemia and what is acute myocardial injury? There should be ischemia and acute myocardial injury to call acute myocardial infarction. For us to call it as ischemia, there should be symptoms like chest pain. Okay, whenever there is decreased blood flow to the heart muscle, there is a symptom of chest pain. That is left-sided chest pain radiating to left shoulder, or jaw, typical type of chest pain, or there can be slight variation in chest pain that we'll discuss later. But ischemia is determined by symptoms or ECG changes, which we'll also discuss later. There can be imaging evidence of new regional wall motion abnormality in echocardiography, or during angiography there can be documentation of intracoronary thrombus. So there can be intracoronary thrombus as well. Now, for acute injury, to say acute myocardial injury, there should be a rise and or fall. Okay, rise and or fall in cardiac troponin. There should be rise and or documentation of fall of cardiac troponin, which is these days it's HS troponin. Okay? This high sensitivity troponin I. Why HS troponin is important? Because HS troponin can increase within 30 minutes and it starts falling down. While our traditional troponin, which was normal troponin, okay, troponin I, that's the time to increase is about 4 hours. So it's it's length of the time needed to increase the normal troponin is high. That's why these days HS troponin is used. Remember, I have said in acute myocardial injury there should be increase in troponin and fall in troponin. If there is sustained increase in troponin, that is in heart failure, or there is a chronic rise of troponin occur in chronic cases. Okay, there is a sustained if there is sustained release of troponin, then that is not the acute cause. In acute there is increase and fall in the troponin. In like acute myocardial injury, okay, myocardial injury due to acute myocardial ischemia. Okay, this can be due to atherosclerotic plaque disruption, or it can increase in myocardial injury due to acute myocardial ischemia, but because of myocardial injury due to acute myocardial ischemia because of our oxygen supply demand imbalance. Okay, imbalance, this oxygen supply demand imbalance can be seen in other causes like our coronary embolism, coronary artery dissection, severe anemia, respiratory failure. There can be due to hypotension, shock. Okay, there can be due to bradycardia. These are the causes which can lead to oxygen supply demand mismatch and increase troponin. Next important thing is increase myocardial oxygen demand. This can be seen in sustained tachyarrhythmia, okay? Tachyarrhythmia or severe hypertension can lead to increased left ventricular hypertrophy and can lead to increased oxygen demand. So these are the basically causes of increased troponin. For acute myocardial infarction, there should be sign or any ECG changes or imaging changes or angiographic changes as well as acute myocardial injury as documented by rise and fall in troponin. So we discussed about the different causes of troponin, rise in troponin as well. Now let's learn about ECG changes. Before learning the ECG changes, we must know how to read an ECG or from where to measure the ST elevation. Okay, for to measure the ST elevation, first of all we have to know the baseline. This one it's written here. It's known as baseline. Okay, this is a baseline. Baseline means the initiation of Q wave is the baseline for measuring ST elevation. Okay, from here, from this baseline we have to measure, and for example in this case is to here. Okay, it's about 2 mm. Okay, more than 1.5 mm elevation is there. So basically to measure ST elevation we should measure from the initiation of Q wave. After that, what are the ECG changes? What are the ECG criteria? Okay, elevation at J point in there should be ST elevation in two contiguous lead with cut point of more than 1 mm. Okay, more than mm in all leads other than V2 and V3. Remember, it's all leads except V2 and V3. In V2 and V3 we have a different criteria. For men more than or equal to 40 years and less than 40 years, there's a different criteria. For men less than 40 years, the elevation should be more than or equal to 2.5 mm, while in more than 40 years it should be more than 2 mm. Okay, while in female it's same irrespective of the age, it's more than 1.5 mm in V2 and V3. For all other leads there should be more than 1 mm elevation in J point, while for or non-STMI or unstable angina we have a criteria of ST depression. Okay, ST depression should be new horizontal or down sloping ST depression of more than or equal to 0.5 mm in two contiguous lead. Okay, two contiguous lead. And for T wave inversion there should be more than 1 mm in two contiguous lead, with prominent R wave or RYS more than 1. We have to remember this to know the ECG changes in STMI. After this, let's learn about what are the causes of ST elevation, whether it's only MI or there are any other causes as well. One of the most important causes of ST elevation is our myocardial ischemia or infarction. After that, there are other causes like acute pericarditis. There will be global ST elevation, acute pericarditis. Other causes like acute pulmonary embolism, or hypercalcemia, hyperkalemia, or hypothermia because of myocardial injury due to our DC shock or trauma. In this case also there will be ST elevation. Okay, if there is any tumor that is invading left ventricle, then also we can see ST elevation. After knowing this, if we have documented, if a patient after this, if a patient comes to us with typical type of chest pain or angina equivalent and typical type of chest pain or angina equivalent, and we did ECG, if there is sign of STMI or NSTMI or unstable angina, then we have to do troponin. Okay, before before troponin, within 10 minutes of patient arrive within 10 minutes of arrival of the patient in any hospital setting, we have to do ECG. And if there is ECG changes of any of these things, okay, any of these things, we do not wait troponin, we directly go for two things. Okay, if our center is PCI capable center, or our center is not capable for PCI. If our center is capable of PCI and we can do within 120 minutes of PCI, then we have to do and with a target of finishing or crossing the wire within 90 minutes. But if we are not able to do the PCI within 120 minutes, or our center is not PCI capable center, then we have to know whether our patient can reach there within 120 minutes or not. If they can reach to the PCI capable center within 120 minutes, then we have to do we have to send that patient for PCI. Otherwise, if the patient cannot reach within 120 minutes, or the patient needs more than 120 minutes to reach to the PCI capable center, we have to do fibrinolysis. Okay, fibrinolysis and send that patient to PCI capable center. Okay, this much for today. Thank you.